Hello, everyone, and welcome to today's webinar, The Impact of COVID-19 on Pediatric Brain Tumor Research and Treatment for Families, Caregivers, and Like-Minded Organizations. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Dr. Annie Huang and Kathy Riley.
Greetings to listeners around the world. My name is Kathy Riley. I'm Vice President of Family Support at the Pediatric Brain Tumor Foundation. I want to extend a warm welcome to this virtual discussion on the impact of COVID-19 on pediatric brain tumor research and treatment, hosted by the Society for NeuroOncology and the Pediatric Brain Tumor Foundation. Before we begin this discussion, I'd like to thank Drs. Annie Huang and Rob Wexlerea, co-chairs of the Pediatric SNO Track Committee, for partnering with us on content development and recruitment of experts to discuss the current state of research and treatment and how it might affect you as brain tumor patients, families, caregivers, and advocacy organizations. Our webinar today will feature 2 different panel sessions, each with 3 experts. We will hear short opening remarks from each panelist, followed by a question and answer session. I'd now like to turn it over to Dr. Annie Huang, who will make opening remarks and moderate our first session.
So thank you very much, Kathy. Welcome, everyone, and thank you for attending this webinar, which is addressing some of the most acute issues we're all facing around the world and how it might be impacting your families and the care of your family members by the physicians. We have a very distinguished panel of experts here, people who range from charge of research institutes that can speak to the impact of research that's being affected by COVID, as well as people who are in charge of trials and people who are beginning researchers. So I will start by introducing Dr. James Rutka, our first panelist. Dr. Rutka is the founder and director of the Brain Tumor Research Center at the Hospital for Sick Children. He's a professor of medicine and surgery at the University of Toronto and has been a pediatric neurosurgeon for a very long time. He will give us some insight into the impact of COVID on research. And our next panelist is Dr. Mariam Fouladi. And Dr. Fouladi is a very well-known pediatric neuro-oncologist. She trained at SickKids. That's our claim to Dr. Fouladi. She is now the executive director of the neuro-oncology program at Nationwide. She is also the chair of the Children's Oncology Group, Brain Tumor Group. She has been leading several consortia focused on innovative therapies for pediatric brain tumor. And she will give us some insight into how the COVID situation might have impact on the way trials are conducted. Thank you, Dr. Fouladi. And our next panelist is Dr. Laura Donovan from the UK, who is a new faculty member, very recently appointed to the Institute of Child Health in London. And Dr. Donovan did her postdoctoral fellow at the Labatt's Brain Tumor Research Institute in Toronto and has done some really fantastic work on immunotherapy of pediatric brain tumors. And Dr. Donovan will give us some insight into some of the struggles in starting your lab in this pandemic era. So thank you all for participating in this webinar, and thank you for taking the time from your busy schedule. I'd like to start the questions, with Dr. Rutka, and then Dr. Falati and Dr. Donovan, and then we'll go around again. Dr. Rutka, you are the director of a very large brain tumor research institute. How has COVID affected the research activities and training within your research center?
Yeah, so thanks very much, Annie. It's a real pleasure to take part in this panel today, and I'm honored to be joining with Miriam and Laura at the same time. So, March was a very strange time for all of us when the pandemic struck North America in particular, other countries perhaps before that, but almost in an instant it shut down most of the research centers and institutes that I'm aware of, with some exceptions. So that is to say, the moment that it was determined that we were in the midst of a pandemic, virtually all kind of wet bench research grinded to a halt. And what happened subsequently is, with a little bit of lead-in time, our researchers, our trainees, students had to close down their wet bench experiments. So freezing down cell lines, terminating cultures, doing all sorts of work to, put everything to rest for a while until we got further notice, at least from higher authorities. And then, we had a lot of animal experimentation that the animals needed to be culled, and this was, very unfortunate and also very expensive and really cost timing-wise a lot of hardship for our trainees and our research scientists. So immediately we shut down in March, and then when we got a handle on what was going on with respect to the pace of the pandemic, we opened up the Research Institute and our Brain Tumor Center to initially 25% capacity. So if you had a lab of 10 people, you might have 2 or 3 people enabled to come to the lab from your lab group. And they could work typically in shifts, but it was very strict, and it wasn't clear that we were going to accelerate the pace of research studies until we got further notice. So we went from 25% to 50%, and then now we're up between 75 and 100%, but that took place over the course of almost 6 months. And there's no question that the impact on trainees has been substantial. So for everyone, for observers in the lab, to masters, to PhD students, to postdoctoral fellows, all of their programs have been hit very hard and influenced dramatically by the pandemic. You can imagine a PhD student who wants to finish and get a PhD thesis defense. That has been, those have been put on hold for a while. Master students with a shorter time window have had to struggle to try to get their work done. We've had, let's say I'm a neurosurgeon, so neurosurgery residents trying to do their research work on a very fixed time frame of a year. So they've lost pretty much 6 months, 7 months of the year in terms of bench research work. Some of the other non-bench sort of wet bench research, like health services research, bioinformatics research, that can be done in a sort of a dry lab scenario. I mean, that type of work could continue, thankfully, with access at times to the servers that may exist in the research institutes. But by and large, it was a very difficult time. So I'll just conclude by saying it's been hard. Everybody's been in the same boat. I know some institutes didn't close down as much as we did. We were taking our orders from a province-wide in Canada approach, and so the communication was good in our system. I think our response to COVID was very good. Our numbers were very good, but it has impacted seriously on the research that we've done.
Thank you very much, Dr. Rutka. Dr. Rutka, I just had a very quick follow-up question to this. So in all of this, how has COVID impacted research funding or the utilization of research funding?
Yeah, I can speak for Canada. In particular, Annie, in the United States, we can hear from others who will be coming to speak a little bit about NIH and other types of maybe more regional funding. But it was announced early on in the course of the pandemic here that the main granting body, that's called the Canadian Institutes for Health Research, they closed down initially their grant offering for the spring cycle, saying that there was no money in the system to support the operating grants of the research scientists who normally, obviously, submit grants this time of year and would expect to be in competition for funding. But all of the money was diverted, it seemed, to COVID funding. And so if you were interested in examining COVID-19 research, then there was an abundance of funding available for that. But if you were trying to get your own cancer research, your brain tumor research grant funded, it didn't look very bright in the initial few months of the pandemic. Then, with a big hue and cry here in Canada, the grants panels opened up, and it turned out that they allowed the scientists to submit their grants but in a delayed fashion to the application process, and so it looks like at least a good portion of the money has come back on board again. But initially, it looked like the funding was not going to occur. So I mean, we're all in the midst of this. The economy is in a very dire situation to a degree. How much money are the governments going to be putting into research and development is very unclear. And that's why it's really important that other agencies that can, at a time of need, can come forward to help us, would be greatly appreciated. And of course, I'm alluding to such agencies as the Pediatric Brain Tumor Foundation, other kind of regional foundations and societies and groups that might be able to come to the charge and help us, because it's really unknown about the government funding.
Thank you very much, Dr. Rutka. My next questions will go to Dr. Fouladi. Hello, Dr. Fouladi. Thank you very much for joining. My question is, how do you think the pandemic has interfered with the diagnosis and treatment for brain tumor patients?
So thanks, Annie. It's an honor to be here, to be part of this distinguished panel. Clearly, as a clinician and a clinical trialist, we have seen both in the adult and pediatric world that COVID-19 has had an effect on screening, diagnosis, and treatment of patients with brain tumors. I think, for example, one of the clear signs is that in the clinical trials consortia, such as COG, there was a dramatic drop, particularly in non-treatment biology study enrollments, particularly in February and March. For clinical trials enrollment, there was also a dip. And thankfully, over the last couple of months, those numbers have started to come up again. So clearly, there were issues with enrollments, but when you look at screening and diagnosis, Dr. Sharpless had actually published a study in Science in June, or a commentary in Science, stating how much diagnosis for adult cancers have been affected and how much we're undercalling diagnosis for adult cancers. So I'm assuming the same would really be true for pediatric brain tumors as well, especially in light of the fact that especially at the beginning during the lockdown, parents weren't taking their kids to pediatricians. If kids were having unclear symptoms like nausea, vomiting, headaches, a little bit of instability, there probably would have been some delay in diagnosis. So I definitely think that those things were affected by COVID, in addition to the fact that, for example, if you wanted imaging and the pediatrician didn't think it was necessarily urgent, and the patient, for example, needed sedation, those were the patients who probably didn't get evaluations in a timely manner and potentially delayed their diagnosis. So I think in terms of screening and diagnosis, those were the problems. What about in terms of treatment? So I think we were lucky in some respects because although especially at the very beginning when there was a complete lockdown, a lot of institutions, particularly for early phase clinical trials, actually shut down those operations and enrollments were suspended. However, what was really actually encouraging and inspiring was that the NCI, the FDA, the EMA, the big consortia all came together and recognized that it was really important for patients to continue to be treated on clinical trials. And so they basically tried to mitigate some of the issues that were happening. So for example, in phase 1-2 clinical trials, where usually you have to see patients in person, they allowed telehealth visits, where investigational drugs needed to be given at the site where that patient was enrolled. The NCI allowed them to be shipped to the homes. In terms of non-critical labs, evaluations and other things, delays were allowed. And they specifically said that deviations that were related to COVID, that were minor deviations, would again be allowed. So I think from that perspective, again, there was a hit, but I think everybody stepped up pretty quickly to look at how they could mitigate that impact. And I think separately from that, one of the things that the NCI has done that has been very good is to look at the longitudinal studies of the effect of COVID-19 on patients, particularly adult patients. So this was a study the NCI opened up a few months ago, and hopefully at the end of September, it will actually open up for pediatric patients as well, allowing us to really continue to follow patients and the impact that COVID has had on pediatric cancer patients with this disease as well. I think you're on mute, Annie.
Annie, it looks like you are on mute.
Sorry, my apologies. I was talking to myself. But I did have a very brief question for you. What would you say to parents as we approach the second phase of COVID about bringing their children to the hospital? Just a very brief message.
Yeah, I think, you know, what has also happened again, in a very good way, has been that we have really stepped up there. And I know Eric probably will talk about this. There was a consensus statement made by both CIRP, COG, the World Health Organization, St. Jude Global Health, and a whole bunch of other groups who really tried to put in effect ways that we can ensure we're screening patients, particularly if they're being admitted, you know, isolating the pediatric oncology patients as necessary, and monitoring them. So to parents who are concerned if they're pre-diagnosis, then I think it is important at this stage to take your children, because we're a lot better off than we were in February, when we really didn't have the ability to screen patients, to test patients for COVID, or really to have the appropriate social distancing and other mechanisms that we have in place that are happening in all the hospitals. And I think for those patients who are on therapy, again, there are very clear guidelines that have been put into place to ensure that we can safely deliver chemotherapy, safely diagnose patients, isolate them when necessary. So I would encourage parents not to delay taking patients to the hospital and ensuring that kids get appropriate therapy and full dose and full schedule therapy for their cancers.
Thank you very much, Dr. Filati. So my next question is for Dr. Laura Donovan. Hello, Dr. Donovan. Thank you for joining us. My question is from one of the audiences. How has pandemic affected the beginning of new research projects or laboratories such as yours?
Well, the pandemic, it hasn't made beginning a new research lab impossible, but the pandemic has made it exceptionally difficult and significantly more competitive in an already highly competitive arena. As a new PI beginning your lab, there are expectations in place and goals which have to be met for you to succeed in your career. Expectations to secure grants, whether they're large or small, to support the generation of new projects, to support staff, to facilitate and help run these projects. Universities, which are a source of innovation and development and some of the main sites of cancer research, are under threat because of loss of funding, particularly from overseas students. Therefore, there are hiring freezes which have been put in place, which means that new laboratories cannot hire staff. A team of people are necessary to generate the required data to apply for grant applications to support more staff and further projects. So at the moment, new laboratories like myself are caught in a vicious circle with needing funding support to bring in staff, but requiring staff to produce data to apply for funding support. COVID has also had a huge impact on training, with social distancing, local lockdowns, building restrictions, and also potential care responsibilities that every single member of the university is facing. Therefore, training staff just aren't available as they previously were. So obtaining licenses to carry out different levels of project work is now becoming a real challenge, which significantly delays any brain tumor research. We're also starting to enter a phase where grants are awarded now on the likelihood that the project can continue to be delivered with significantly reduced contact or local lockdowns. This means that wet lab, bench work, and animal work is significantly affected. This is understandable, but it does add an additional layer of competition. But as a new PI, you can't let it hold you back. You just have to find a new way of addressing the project question for the time being. Careers of many people have been affected, from undergraduate students, PhDs, technicians, postdocs, fellows, and key staff that maintain the labs. The pandemic's prevented students from finishing their degrees or PhDs on time, as Dr. Rutker mentioned. It's also impacted principal investigators' ability to apply for or initiate startup grants like myself, which are essential for bringing in beginning new laboratories. But we became junior principal investigators for a reason. So we have to maintain morale and positivity throughout our, however small, teams, and this is really critical. We have to find a way to continue to advocate and stand behind our brain tumor research projects and our brain tumor research programs to develop the next novel therapies, because although we are in a COVID pandemic, the incidence of brain tumors and tumor recurrence haven't decreased, meaning that new projects and new laboratories are needed now more than ever.
Thank you, Dr. Donovan. I think I will bring our next questions to the panel as a whole and get input from everyone. So we can invite Dr. Rutker and Dr. Falati back. And this is a question to all of you, so whoever wants to jump in. It's a question about, have we learned any clinical lessons from COVID that might be applicable to the treatment of brain tumor patients? From all the research that's been done on COVID. There was a question from the audience with respect to perhaps learning more about the immunology of cancer or immunotherapies for cancer.
I can help answer that one.
Thank you.
One of the problems that we're facing is that the cancer research efforts across the community, academics, government, and industry, they've reduced focus, or any research related focus has now been moved on to the pandemic. So many complex modeling systems of cancer have had to be suspended for the time being. So it's quite difficult to try to draw any links that there might be that there may be any innovations for the treatment of cancer. There was a study recently published by the lead author Singh, which was published in a very good journal, Cell, and they show that COVID has been detected in brain and cerebral spinal fluid, which means that this novel virus has actually found a way to cross the blood-brain barrier. Identifying therapies for brain tumors which can cross the blood-brain barrier has always been a hurdle which we faced when we try to develop new treatments. So this study showed that the virus appears to have found a way to infect pericytes, which is a type of cell which lines and is located within the vicinity of the blood-brain barrier. And these cells seem to actually act as a gateway or an entry to the central nervous system. So this, for example, might be an opportunity that we can exploit as new therapies to gain entry into the central nervous system. But what we can also do in answer to your question, though, is we can use cancer research to help inform strategies to treat and prevent COVID. Cutting edge cancer research is based on the understanding of immunology and understanding how the immune system can be harnessed to fight cancer. That means we're facing the same problems as we try to identify how the immune system reacts to this virus. In cancer research and cancer immunotherapy, we're constantly profiling the immune system to identify which treatments patients will most likely respond to. So if we use this same profiling approach and apply this to COVID, it can show which patients are suffering from, for example, hyperinflammatory state, and those which may have failed to make an immune response, and those which may need help with immune activation. Also, as cancer researchers, we're very familiar with cancer heterogeneity in and out of the immune system state. And so trying to understand why some patients respond to cancer treatments and other patients, why some do and why some don't, is a challenge that we frequently face. For example, we hear reports almost daily now of hospitalized patients giving partial responses to certain treatments, and how some drugs may or may not be as effective as we previously thought, but this actually might be a reflection on the heterogeneity of the disease, which is something, again, that we're very familiar with in immunotherapy and in cancer research. So it's important that all patients aren't treated the same, as there may actually be subtypes of patients. So from our understanding, dealing with tumor heterogeneity between and also within patients is something, as cancer researchers, we're very familiar with. So we're learning that treating all COVID patients the same may cause mistreatment opportunities. So I think that's something that from cancer research we can use to help treat or to find new insights to COVID.
Thank you so much, Dr. Donovan, for that very detailed answer. I just have a question to follow up with Dr. Rutka. There was a question from one of the audience about how has COVID impacted surgeries for brain tumor patients, and maybe you can offer us some personal and general experience in relation to that.
Yeah, so interestingly, back in March, as I mentioned at the beginning, everything was shut down in terms of surgical procedures except for emergencies and dire emergencies initially. And I would say, thankfully, Annie, a child with a brain tumor, so mostly we can identify children that have malignant brain tumors, they would be treated as high priority, and they would be considered emergency, and they would get their surgical procedures that they so desperately need, even in the face of the pandemic. So it was encouraging for me to see this unravel and to see our patients being treated in a very timely fashion. As you know, we kept our NeuroOncology conferencing going, so all the decisions that were made around these children after their surgeries could be done in a timely fashion. So we really don't think that children who desperately needed the care that they deserved were put at risk or suffered any consequences. So I think that that's a good thing. The other thing I think that COVID's done to help us as surgeons is learning how to operate in and amongst a pandemic, because initially it was unclear how to, don and doff the personal protective equipment, which patients needed to go on ventilators. There are certain neurosurgical procedures that involve the airway that were thought to be super high risk for infectious and contagious purposes. So a lot of technologies have evolved to make those types of operations even safer for patients who have brain tumors in and amongst the the pituitary region, for example. I would say that the children that had more benign tumors that you would recognize, and maybe a seizure kind of disorder problem, where it was not urgent emergent, but rather kind of semi-urgent or elective, we definitely saw that some of those children had to wait a little bit. So for example, we have a strategy of treating children with benign tumors by and large that are deeply seated in certain regions, mostly low grade, a variety of types with the laser, so laser interstitial ablation. And those cases kind of grinded to a halt for us initially. But just last week, we were able to do like a dozen of those, get caught up again. So we had to wait a little bit, but I don't think in the process of waiting, those children with the more benign related tumors suffered any significant consequences. So through strategizing as to the tempo at which certain children with brain tumors should be evaluated, we prioritized them in a manner, I think, that everybody got the care that they deserved in the time frame I thought that was appropriate for them.
Thank you, Dr. Rutka. Dr. Falati, I have one question for you in the last couple of minutes. I think you touched on this a little bit. Many of our children are on trial.
Sorry.
Many of our children who are on trials sometimes have to travel a distance, and their ability to get the innovative drugs depends on access, whether drugs come on time, and whether they are able to travel to the center that dispenses these innovative drugs. How has COVID impacted that?
So that was clearly a concern at the beginning of COVID, because patients were unable to really get on phase 1-2 clinical trials because of the restrictions that are very clearly stated in those studies. But as I said, I think the NCI and everybody else stepped up pretty quickly to mitigate those circumstances and allow deviations. So I think a huge thing that they allowed was that drugs didn't have to be given and prescribed at the home, at the institution where that drug was being delivered or that trial was being conducted. They allowed us, which usually they would not, allowed us to basically ship those drugs to the home, to do telehealth visits, to look at toxicities and things like that. And even for some of the biology and pharmacokinetic studies, which are part of those studies, they allowed us to skip it, perhaps do it later on in the second or third or fourth cycle. So I think, yes, it definitely had an impact on patients, particularly in terms of travel, but we did try and mitigate it as much as possible with the allowances that the NCI, the FDA allowed us.
That's great. Thank you very much for your answer. We have 1 minute, and I wondered if any of you had some words of wisdom for our audience. Other than to keep safe. I think thank you very much for sharing insights into the different challenges we've had. I think it speaks to the resilience of our patient population and our work, that it has continued despite COVID. And as Dr. Donovan and Dr. Rutka and Dr. Falati has outlined, we have made do, and we've been very innovative despite the limitations of COVID, to continue to do research and take care of our patients to the best of our abilities. So I think we've come to my time up, and I'll pass this session on to Kathy Riley. Thank you so much for answering my questions. Thank you.
Thank you, Dr. Wong. For our second session, we have another distinguished panel of 3 experts, including a parent who has experience personally with clinical trials. Before I introduce our first panelist, I want to remind our attendees that we want to hear from you. And as our panelists are sharing their remarks and we have our panel discussion, please go ahead and enter any questions you have into the chat box on your GoToWebinar control panel. To begin our second panel discussion, we'll hear first from Dr. Dwayne Mitchell, Assistant Vice President of Research and Associate Dean for Translational Science and Clinical Research at the University of Florida College of Medicine. And it is my pleasure to introduce Dr. Dwayne Mitchell.
Well, good afternoon, and thank you for inviting me to this important webinar and panel discussion. I thought I'd give just a little bit of perspective of our response to COVID-19 and how it's impacted on a pediatric brain tumor research program, but also just touch on, I think, some of the lessons that we've learned during this pandemic response that actually I think can be hopefully applied in a positive manner to facilitate our research efforts in the future. So I had the opportunity to step into a role of looking at our clinical and translational research programs here at the University of Florida in mid-February, which was about 2.5 to 3 weeks before we were in the midst of the shutdown due to the rapidly spreading COVID pandemic. And so from an institutional view, our focus began trying to address the challenge of how do you really shut down and evacuate over 5,000 faculty and staff engaged in the research enterprise, but at the same time preserve, critical functions and essential activities that would be required to bring the research back online. And then after that process, very rapidly going into a planning on how do we resume the very important clinical and laboratory research priorities in a safe manner and an organized way that would allow investigators to continue to pursue their research objectives in the midst of the ongoing pandemic. And so at its peak, this involved probably, I looked at 10 meetings a week with various leaders throughout the university, and many sessions in between those organized meetings to really figure out how to orchestrate that process. As you heard from our prior participants, this has had a dramatic impact on the level of research that people have been able to engage. One of the processes we went through on the clinical research side was looking at the prioritization of clinical research and clinical trials and how we would address that. And it was determined that clinical trials for patients who had significant illnesses where a clinical trial option may be the best available care option for those patients should be preserved and should continue through even the shutdown. And so for many of our pediatric brain tumor patients who were enrolled on interventional treatment trials, those activities continued, even though many other studies were discontinued. And as you heard, there were a lot of adjustments and allowances that needed to be made to allow for the safe persistence of those clinical trials. But pediatric brain tumor patients were prioritized as one of the areas within the health center that we wanted to ensure at least clinical trials options remained available. I'll just touch base quickly on things that we have learned already that I think perhaps after this response is behind us, we may actually leverage in a meaningful way to help our research. So one thing I think we've all learned is that processes don't have to take as long as they used to be implemented in a university setting. We certainly don't want to compromise quality or safety, but I think we've all redefined the timelines in which you can make decisions and execute on initiatives. Of course, being forced to do that with this pandemic, but I don't know that we can. We should go back to perhaps the timelines that we've had in the past. And so maintaining a sense of urgency and importance certainly has shown us that there are things can move quite more efficiently. And then the second piece is obviously the use of technology. I think we all long to getting to the point where we can meet face to face and not have the barriers of social distancing and other precautions that limit our abilities to communicate. But at the same time, I think we've all gotten used to using technologies that perhaps we weren't using before that can make it easier to reach out, particularly across great distances, or to connect people together using televideo and other conferences and mediums such as this. So I think those are just two examples where perhaps we were forced to accelerate how quickly we get things done and to use new tools and technologies we weren't using because of the pandemic. But I think these are then experiences that we'll be able to leverage to enhance our pediatric brain tumor research going forward. And so I will pass it to our next panelist who will discuss from his perspective. This is Dr. Eric Bouffet, who many of you know is a very renowned pediatric neuro-oncologist at the Hospital for Sick Children in Toronto. He also has extensive experience in pediatric neuro-oncology care and research in developing countries and both nationally and internationally, and so brings a unique perspective to how the pandemic has impacted pediatric oncology in general. So Dr. Bouffet.
Thank you, Dr. Mitchell. I'm not in my office because I'm in a quarantine coming back from France, so you may not see me very well, but I apologize for this. So I wanted to give the perspective of a pediatric neuro-oncologist here, and particularly in the context of the work that we have done internationally. The first thing is when this pandemic started, we really identified early on the issue of where are the kids here. And we tried to collect information and to put in place a system anticipating that the children would be perhaps the collateral victim of this pandemic. And at an early stage, this was absolutely denied by many authorities. For example, in Canada and in different countries, we asked to have some funding to collect the data on children with cancer in order to document the impact of the pandemic on the incidence of cancer and particularly brain tumor, and to figure out whether this would have an impact on the delay to diagnose brain tumor. This was denied by many authorities, and in fact, the only country that has been able to track down information is the United Kingdom. We are doing this work in Canada, but this would be with some delay. And the information we have so far suggests that there has been a significant drop in the number of patients diagnosed with brain tumors. And it's interesting, in the UK, the biggest drop was in London, which means in a large city compared to the smaller cities. We don't know exactly why. We had some mixed messages also, for example, from Ottawa, when they had a cluster of brain tumor, and the interpretation was that because the parents were supervising their children during the time of lockdown, they were more aware of the symptoms that were associated with the brain tumor development. So we don't know yet how to interpret this, but there is some evidence that this pandemic has impacted and has caused some delay in the diagnosis of brain tumor, as already suggested by Dr. Fouladi. The other question that we had was whether there was an issue with the COVID infection amongst patients with cancer, and of course, in particular for brain tumor patients. In this context, we decided to work together between the International Society of Pediatric Oncology, the Children's Oncology Group, St. Jude, and different groups around the world, and to have a registry to collect information on patients and kids with cancer diagnosed with COVID. So the collection of data in this registry is still going on. So far, there have been nearly 1,000 patients registered in the registry. And it's interesting to see that the brain tumor population accounts for less than 10% of the patients. So it seems that most of the patients diagnosed with COVID and are patients with leukemia, and the brain tumor population is not as affected as the rest of the patients with cancer. Why? It may be related that most of the patients with brain tumor are treated as outpatients, and many have received or are receiving oral medication. For example, for the number of patients with low-grade glioma or high-grade glioma, most of the treatment is orally given. And looking at the severity of the infection among patients with brain tumor, we have some data, not a lot of data, but a minority of patients have required hospital admission. That's around 30% of the patients who develop an infection. And a very small number, and 2, in fact, out of the 64 that we collected information on in the registry, required intensive care admission. There have been no deaths in the population of children with brain tumor on the data from the registry, and no death associated with COVID, which suggests that, as we have seen in the pediatric population, most of the COVID infection in children, but also in children's cancer have been essentially benign. So it doesn't mean that we shouldn't have any protection. And in fact, we have worked very on with the different society to put in place a strategy to try to uniform as much as we can the care of the children with cancer. Now, this has some limitation, and as already mentioned, you know, to change the interaction with patients and families from a physical interaction, a face-to-face, into a virtual interaction, as we did a mini consultation through video conference, doesn't really have really a real. It's not for me something which is a progress, and in particular when we want to disclose a diagnosis, when we want to disclose a relapse, or when we deal with patients in palliative care, we still want to hug, we still want to express our compassion with a mask and without with the distancing. So this had a real impact on the practice, and we want to express here our sincere apologies for this, because this has been really one of the collateral effects of the pandemic on our interaction with patients and families. So I will stop here. I don't know if I should expect any question. If not, I want to introduce Camille, who is a mom. She's the mother of Caroline, and Caroline has been diagnosed at an early stage of her life, 1 year, with disseminated low-grade glioma. And Camille has been through a number of experience with her daughter, and she wants to share her experience as a parent of a child. Camille, yours.
Thank you, Doctor. As Doctor mentioned, my name is Camile Connor from Woodstock, Georgia. My husband and I have 3 children, identical twin 7-year-old girls, Carson and Caroline, and a 9-year-old boy, Stafford. Caroline was diagnosed 3 days after her first birthday in 2014 with a grade 1 juvenile pilocytic astrocytoma attached to her optic nerve. And in 2015, after our chemotherapy option was unsuccessful and a partial resection was complete, we saw that the tumor metastasized. This, of course, put us in a very special and unusual category in which the tumor tends to do what it wants, when it wants. And as a result of that, we have tried 3 to 4 to 5, we sometimes lose count, different chemo regimens, a phase 2 immunotherapy trial with poly-ICLC that was unsuccessful, a phase 2 MEC trial that continued on for about 9 months, but ended with noteworthy side effects. And now we are currently wrapping up our second phase 2 immunotherapy trial with a pegylated interferon that has given us 2 years of stability. Unfortunately, this trial is now coming to an end because it's no longer being manufactured. So after 6 years of treatment and 3 clinical trials, we have definitely experienced many settings within the medical world, from long hospital stays to MRIs, regular clinic visits, hours and hours in infusion, and feel like we are definitely experiencing the differences from what we knew as the past sort of medical world and what we considered our normal to what we're living in today as it's been impacted by COVID. I should start by mentioning that we consider our family blessed in the sense that we have been on this journey for 6 years. We've established relationships with nurses and the doctors and all of the healthcare workers. And that's really been a huge benefit to us during COVID. Without these relationships, the experience that I'm going to describe next would be so much harder. And I've confirmed this with other conversations. I wanted to make sure I was representing a broader population of parents as I talked about this experience. So today, now, when we go to appointments, in fact, we just went to one on Monday, We're required to go alone, just one parent and the child, which is also the case for appointments, for scans, and for long hospital stays. The minute you step off the elevator, you're met with an empty lobby and one representative to take your name. So no TV, no noise, no people behind the counters greeting you with friendly smiles and welcome backs. And we then walk through the very empty hallways and are approached by one nurse at a time wearing the classic mask that we all know very well now. And you're taken to a room to sit alone until you're seen by the doctor or PA. And while nobody really likes appointments, I will say that pre-COVID, these appointments were as enjoyable and fun as they could be for parents and for Caroline. So we don't really want to be in this on this journey. We don't ask for it, but given the circumstances, we did enjoy our visits to clinic. We got to see the people that we now consider part of our family. We get to share stories, catch up, visit with therapy dogs of the day. There's always one or more organizations in the building providing entertainment and crafts for children, snacks, or some variety of distraction that we all really need so much. So my point to all of this is that in a journey like this one, the human element, the friendly faces, the feeling of family and support, whether it be financial, distraction, open ears, that's all invaluable. Sometimes in a journey like this is the only environment where we as parents get to feel somewhat normal because people just get it and they don't ask a lot of questions, they just let us be. And unfortunately, in the environment with COVID, those elements of distraction or just feeling normal really don't exist. In addition to the experience of the actual clinic or hospital setting, we are thankful that because of our trial, we're considered essential. One of the other doctors mentioned this before, that some of our closest friends are not considered essential, so their scans have been delayed and or postponed or canceled. So ours have not been, although scheduling is difficult with a short staff, we have been able to continue with our timely scans, and we have continued to get our medicine on time. Our medicine from the beginning of this trial was shipped directly to our home, so there was not a change in that. We also are thankful that we have not had long hospital stays in the last year to 2 years. But from what I understand, with parents in our community, their children are experiencing reoccurring tests and retests for COVID. So in addition to the stress of going to the procedure and or being in the hospital and coming out, they're asking to be tested in and out, and sometimes up to 5 and 6 times, which is quite traumatic for a child and painful. And these children are already dealing with quite a bit of trauma. So this is all to say that COVID has truly changed the experience for patient families. And what we're all hoping for is that we can begin to see a definite consideration for the mental health and well-being of families, balanced with the safety and keeping our children safe and healthy, which we all know is not an easy balance.
Thank you, Camile, for sharing those remarks with us. I would now like to invite Drs. Mitchell and Bouffet to open your mics, put your cameras back on, and we'll have a brief panel discussion. We have already received a few questions. So I will start with Dr. Mitchell. We had a question about the how has the pandemic impacted research funding that Dr. Rudka addressed in Canada. And could you talk about in the US, how has the pandemic impacted research funding?
Sure. Similarly, there has, particularly early on in the pandemic response, there was certainly a mobilization of resources and really a shift of resources to focusing on response to the COVID-19 pandemic. This occurred through mainly, although not exclusively, some increased funding through the federal government specifically for COVID-19 research. And some of that was disseminated through the NIH and other funding institutes, so that if you were conducting COVID-19 research or saw ways to respond to the pandemic with your research, there was certainly an increase in resources that were available for that purpose. The biggest, another area where we've seen a dramatic impact has been on the private funding side of research, whether it be through foundations or even industry partners that may fund research. The uncertainty around the financial landscape caused certainly a pause in the availability of that funding in many cases, and certainly events, fundraising around events, which is often very foundational to the way that private organizations raise monies to support research were dramatically impacted and continue to be. So we've seen a decline in brain tumor research availability across many of those organizations that depend and utilize events as a predominant means for fundraising. So we're starting to see some recovery as we're moving forward, but this is still an area of great concern.
Thank you, Dr. Mitchell. We had a question that came into the chat box, and I think I'll ask Dr. Bouffet to address. Do we know how pediatric brain tumor patients currently on or off treatment respond to COVID if contracted?
So can I ask you to repeat, because your voice was cut off? So sorry, Kathy.
I'm happy to repeat. Do we know how pediatric brain tumor patients currently on or off treatment respond to COVID if contracted?
So once again, so it's a work in progress. So when we started to talk about the registry, the pandemic was already on, and we are collecting data. And in fact, this was only at the end of August that we started to have the first information on these patients. So all the data I gave you are very preliminary. So we have data on 64 patients with brain tumor, and you have to realize it's around the world. And in fact, half of the cases were from Brazil and Argentina. There are a number of reasons for this. One is certainly the lack of enthusiasm for people to share their information before they publish it. We knew that there were many cases in New York, for example, but New York wanted to publish their data before they share the data with the registry. So at this stage, the information we have on patients with brain tumor who got COVID is very, very limited, I tell you. What we know is that the children who required admission and the patients who required intensive care, where the children were on intensive treatment, certainly, because we identified that a low blood count was associated with a high risk of complication associated with COVID.
Thank you, Dr. Bouffet. I'd like to direct a question to you, Camile, as our caregiver parent expert on the panel. To what extent has the pandemic kept parents from bringing their children to healthcare settings for treatment or follow-up, either in your experience or in the network of families that you're familiar with?
Mm-hmm. So I know that there's definitely been a delay in thinking about going into the healthcare facility. I believe that the scheduled procedures or appointments have been the parents in our community have felt safe with those because they are being monitored and separated. They're doing a good job spacing out the schedule. However, the spiked fevers and requirement to go into the ER, the reaction to those has been extremely delayed, and I believe that people are holding a little bit longer, being a little bit more cautious about the decisions that they're making before they just jump in the car. Where this used to be a process where you very naturally just got in the car as soon as you hit 101, people are thinking twice and hesitating.
Thank you for that, Camille. I have another question, Dr. Mitchell, I'd like to direct to you. What is the impact of COVID-19 on enrollment into pediatric neuro-oncology clinical trials?
It's a great and important question. I think because of many of the topics that were discussed today, I think the biggest impact has been certainly on the burden on families, parents and the participants, the children that would be participating in these trials. We know that participating in clinical trials, while maybe perhaps one of the best options available for treatment, it does oftentimes involve, either more frequent appointments or a greater burden on the parents and the family to remain a participant. And then the pandemic has obviously, with the constraints that you heard about in terms of the number of people who can be there to accompany a child during visits, the limitations on what can be done face-to-face, has made that burden even greater. So I think that the effort that has to be mounted for families to participate productively in trials has been the largest impact. And our own institution, because pediatric brain tumor trials were prioritized certainly for treatment of some cancers as essential trials that we needed to find ways to continue to support, we actually had experienced somewhat of an increase of enrollment across trials over the last several months. Predominantly, we think, due to there not being as many available options at some centers to participate in trials. So perhaps a wider network of families who could make the trips or the journeys or the extra commitment that it took to participate actually resulted in a net increase over the period. But I think that while that may have been an institutional experience, I think it was reflective, though, of the broader challenge of being able to maintain these options for families, and also for the burden that it places on families to be able to participate in that. Geographically, there were perhaps less options even available for families to pursue during the shutdown. So I think we're recognizing that this is an important area to keep available, but navigating the challenges of the pandemic has certainly created constraints.
Thank you so much for that. We've reached the time in our webinar where we'd like to bring back all of our panelists to answer some questions. So if I could ask Dr. Wong and our first three panelists to join us so that we have everyone on the screen, and unmute your microphones. It's great to see all of us together. We'll be able to field probably just a couple of questions before we conclude this webinar. And I have one question that I would ask of our full panel, and anyone can answer. And then I'll hand it over to Dr. Wong for a question. But my question to the entire panel is, what, if any, silver linings have you found regarding research or patient care in the midst of this pandemic?
I can maybe address that at least in part. I think one of the great innovations that we managed to do in record time was to allow telehealth visits and bring in some of the remote monitoring, remote remote viewing of patients, assessing toxicities that way to a degree at least, and really being much more flexible in how we contact families and contact patients and conduct our trials. So I think those will have long-lasting changes in how we actually conduct therapy, because some of these visits, especially if patients are stable and they're not during the initial dose-limiting toxicity time frame of a study, are things that we've always wanted to adopt. It just, you know, there was never the perfect group and the perfect time to get all of this up and running. But I think the pandemic sort of became the necessary events that made this happen truly in record time, I think, in most of our institutions. And I think, again, these concepts of being able to ship some of these drugs directly to the home so people don't have to travel hours and hours by plane to come to get a drug that they've been on for a year and a half. Some of those things have been really wonderful, I think.
So I will just come on and mention something that we laugh about a little bit in the parent community, but something that COVID has brought forward for us is an entire nation now and world that is more aware of cleaning hands and protecting, you know, staying germ free. So the rest of the world is now living in our world where we have to be careful for the spread of germs. So that's been a bonus for us.
Yeah, maybe would only add that it's sort of echoing on Dr. Filati's comments. You know, we have seen clinical trials for COVID-19 from be developed, reviewed, approved, and opened in 3 weeks, which, you know, prior to this era, we would talk about the timelines of getting a clinical trial up and going and open being, you know, 6 months, a year. It could be, and I think while there was obviously an urgency that drove those activities, I think it has, at least I know in our institute, redefined, you know, how we can, what's possible to streamline some of the inefficiencies that happen in terms of bringing clinical trials forward on a routine basis, and realizing that we can find ways to still be critical in that process, but be also a lot more time efficient. And I think that hopefully those lessons will be carried forward into clinical trials in general.
I'll pop in with a question. I guess it's maybe to Dr. Mitchell. How do you think this, along the same lines as what Kathy is asking, how do you think COVID has helped us move technology along for cancer therapy?
Well, I think the telehealth examples that Dr. Filati talked about, I think is probably I think a broad institutional experience. I can't tell you how long we had conversations about how we were going to bring telehealth into the, you know, sort of mainstream of the practice. Perhaps one other area that's touched on the clinical trials world is there's an increasing need and interest to do more research where people live. You know, we put not just a tremendous burden on families to have to travel for trial participation, but we also know that doesn't represent then the full segment of the patient population that we're trying to benefit with these new treatments. We're selecting in a way for those families and patients who have the ability to navigate all the obstacles to come to participate in a trial at a you know, an institutional center. So figuring out how we can safely push research into the communities where people live is not just has the benefit of trying to lower the burden on patients, but it will actually give us a better representation of the population we're trying to help.
Thank you. I have a couple of live questions as well from the audience that maybe I'll put out to Dr. Filati and Dr. Bouffet. What can be done to change the one parent at bedside policy? Who can affect a nationwide change? I guess it's two questions, and the third one, do we really have to wait until a vaccine is available? Maybe I'll start with Dr. Filati and then Dr. Bouffet.
That's such an excellent question, because honestly, even for us as care providers, we always like when we can have both parents or both caregivers or other extended family in a room, particularly when we're giving a difficult diagnosis, if there's progression, if we're discussing new therapies. So I will tell you that we do make some exceptions for newly diagnosed patients, for patients who are at a point where there has been progression and we really feel it's necessary to have the full support of the family there. We have made those exceptions. So I do believe it's possible if we continue to sort of make sure there's social distancing, masking, and all those issues. So I actually try and make that exception as much as possible when I think it's necessary, and perhaps demonstrating its safety and demonstrating the fact that, you know, these kids are being tested, the families are basically masking, social distancing, maybe a start to making this a more widely acceptable approach.
Okay, and then maybe I'll ask Dr. Bouffet, I'll just repeat the question. So who can affect a nationwide change in terms of this one parent at the bedside policy, or do you think that's possible at all?
I have to say I have no idea. It makes me cry because I'm a very, emotional person. I have a European background, and my education is all in contact, communication, hugging, kissing, and all this has disappeared. And it reminds me how we practice, because I work a lot in China. In China, there is a natural distancing, and I was trying to fight this when I was working in Shenzhen over the last few years, and all this has collapsed with the pandemic. I think it's going to take many years for our group of pediatric oncologists to recover from this experience and to go back to normalcy. I'm not even sure if the vaccine is going to change this. In addition, there has been so much diversity in the recommendations that were made regarding masks, regarding distancing, that as a community we are a bit at loss with what we should do and we shouldn't do. But I fully agree that we should, as much as possible, make an exception, particularly during difficult times, to bring a family, and in particular the extended family, because mom and dad is not enough in many cases. And when we see the role of grandparents, for example, it would be critical to advocate for a larger group of people to attend this important time.
Thank you, Dr. Bouffet. I have a comment rather than a question, but maybe the panel can weigh in. It says, there are foundations supporting families. They're finding more requests for help with accommodation. As places like Ronald McDonald House are closed, and the financial help for patients wanting to travel to trials and treatment is now more limited, and it is much more difficult to fundraise at this time, I think, which we've all touched on. Are there sort of advice, I guess, or pointers that the panel can offer to the person with this comment or question?
Yeah, I could maybe provide just a quick comment along those lines. I do think that many of us are, for the past several months have been, just responding and reacting to the pandemic and the conditions that were, continue to rapidly change. But I do think we're at a point where also figuring out how to execute on our priorities in the midst of the ongoing pandemic is something that many of us are turning our attention towards, and I think just forums like this, but in many ways the funding support for families and for research and for clinical trials in areas that are not related to COVID-19, I think we all recognize those are extraordinarily important. And I do think there is as a community, people are able to start recognizing the need to refocus on those objectives that we all have and had certainly prior to January, February of this year, and figure out how do we re-engage in those. And so I think that's beginning and will continue.
Yeah. And I think I just wanted to add a comment to what Camille had said before. I think that, and to Kathy's point about there's always a silver lining to a cloud. And I think that we are perhaps becoming a more empathetic society. We perhaps can walk in the shoes of some of the people who face this on a daily basis, the isolation, the having to go to places and being inconvenienced, things that we take for granted every day, and perhaps also allowing families to connect in a way in our very busy lives that hadn't happened before. But I think those are blessings, and there's always blessings to a challenge, and taking up the challenge and making it something better is always a good thing. So I think those are all the questions that I can see, and I think we're running out of time. I don't know if there were any questions that Kathy wanted to raise.
I think we've covered the majority of questions in the chat box, so thank you. We have reached the end of our time together. I would like to thank our panelists for their time and for sharing their expertise with us today. I also want to extend thanks to the Society for NeuroOncology, Chaz Haynes, and Shelley Presley for their tremendous help and support in production of this webinar. And I want to thank you, our attendees, for your participation, for your thoughtful questions. If you are a family in need of support, please reach out to the Pediatric Brain Tumor Foundation. I believe on the next slide, if we can advance to the next slide, there is some contact information. You can reach out to the Pediatric Brain Tumor Foundation at this email. If you have questions about the Society for NeuroOncology Online Learning Center, you can reach out to Shelley Presley at the email address listed here. Thank you, everyone. Goodbye, and have a great rest of your week.
Thank you. Thank you, everyone.
Thank you.
Bye-bye.